Well, welcome back. And so, what ended up happening about when I was on vacation and around in September, around Labor Day, my stepsister called me, and she's a sportscaster for a small area up in the Michigan area, and she said they were doing a thing through the sports where they were honoring hospice and hospice-related activities, and I think she wanted a picture of me because, I mean, I had done hospice medicine for quite a while. I got involved in hospice when I was here in about 2000, early 2000, and I don't know, it was about 5 or 6, and hospice in this community is a very valuable resource. In order to qualify for hospice, patients have to have a disease, any type of chronic disease, and the question you have to ask yourself is, would I be surprised if the loved one that I was taking care of or that I knew died in the next 6 months from this illness? And if the answer is no, I would not be surprised. Doesn't mean that you would be happy or that you would want that to happen, but would I be surprised if the loved one that I was taking care of died in the next 6 months? They had bad lung disease, they have a bad heart, certainly if they have cancer. Cancer is kind of a no-brainer. When you've exhausted all the chemotherapy and there's no other option, then hospice therapy would be a resource. But if you wouldn't be surprised, then hospice is a viable choice for your continued health care. The advantage of hospice is that it is the oldest capitated program by Medicare. I mean, every hospice gets X amount of money to take care of the patient, and they have to provide social work, they have to provide spiritual care, they have to provide post-bereavement services to the family for the loved one that has passed away. They provide all medications related to the hospice illness, including pain management and anything else that goes along. So you have COPD, they're going to provide your oxygen, they're going to provide your breathing medications, they're going to provide other things that you need. Plus they have nursing support. The whole object behind hospice is to reduce your worry and you're getting those valuable people to come out to your house, nurses that come out to the house to help take care, CNAs that come help do the cleaning and some of the work that it takes to take care of a bedridden patient and things of that nature. So these are the things that hospice provide. The problem is getting patients over the hump of hospice. Hospice is unfortunately like Norman Bates at the Bates Motel. Anthony Perkins, when he played that role, he never, if you saw that movie, and it was a defining role for Anthony Perkins. So he was always Norman at the Bates Motel. It didn't matter what other, Psycho was the movie, Alfred Hitchcock, but whatever he did, they always referenced back to Norman. That's how you remembered that gentleman. However, that's bad because he was a better actor than just Norman, although he did a great job in that show. But one of the things is hospice has that same thing. If I talk to you as a patient about hospice, immediately you're going to think I'm going to put you in a room, I'm going to give you morphine, and I'm going to, poison you to death with the morphine. I'm going to put you to sleep. And that is unfortunate because hospice does so much more today. This was a program created in the 1980s. It wasn't understood very well. It has morphed into a better program than it was. It encompasses a lot more diseases, ALS, Parkinson's, COPD, congestive heart failure, obviously cancer. But any disease that doesn't have a cure, that is progressive, is hospice appropriate, and there are certain criteria that Medicare define. And you as a patient have the right to choose any hospice that's out there. Once you've decided that that's where you're going to go, I think there's like 5 or 6 hospices in Pahrump. There was only one when I started, and it was Nathan Adelson. and then came Comfort Hospice, and then came Infinity and ProCare, and all these other hospices that exist in the community. And in general, they are governed by Medicare. There are certain rules, but I subscribe to the philosophy that a lot of doctors can practice medicine, but very few doctors can practice hospice medicine. It takes a real compassionate person to be able to go into a home and help people in those last few days. And the other key I encourage people to do is you should probably get involved in hospice, even if you've had a loved one, maybe even volunteering for hospice and helping out, and helping families cope, and then be there for them. Also helping to suggest that a hospice. I mean, in today's world, it's almost impossible that you haven't had a loved one that hasn't died suddenly that's been involved in hospice. And one of the things you can do is choose hospice a little bit earlier than you might think. Don't wait until the patient is, taking their last breath to call up hospice and say, can you come help us? And by then it's too late. I mean, you want to get hospice involved in the care of the dying much sooner than the last few days. When medicine has taken away and there is no more days, medicine can't add days to your life. Hospice can add life to your days, and so that's a very key point. I think Nathan Adelson used that as a slogan, and it's a very true statement. It's very true for what hospice does, and if you've never been around hospice and you don't understand hospice, it's one of those, they take away the veil of cure. That's where I learned about pain management. That's where I did a lot of, things. You're forced to use high-dose medications. You understand the side effects of medications. When I was working in an inpatient unit with Nathan Adelson, I had a relatively young person that was dying. She was a very nice lady, and her husband, I went into the room and I was trying to explain to them the razor's edge between sedation and pain relief, and the husband looked right in my eye and said, well, you better sharpen your pencil, because he wasn't going to tolerate anything less than keeping his wife pain-free and alert. And that's very difficult to do. I don't know how I did it in that particular case, but I did. And so you just have to be able to, use the different medications and learn how to do that. I'm hoping now that, medical marijuana is here, that, people are using that in addition to some of the other treatments, for, cancer and cancer cures. But I think, you as a family and you as a patient need to keep in mind that, hospice is a very viable thing. If you have a lung condition, Medicare says you don't have to die in the next 6 months. You just have to have a reasonable probability that you might expire in the next 6 months. So keep it in mind. It's one of those programs that I think is not, it's a little competitive between different hospices. They all kind of want their business. It's like a home health agency. They want to try and get in there. You may have subtle differences between different ones, but again, it's a Medicare program. They have to do it a certain way. Anything that's associated with Medicare is pretty much governed by Medicare rules, and Medicare rules on how much they pay, what they can pay for, what they can do, and what they can't do. And so keep that in mind. When you have a commercial insurance, it's a little bit of a different story, but not all commercial insurances have a hospice benefit, and they only limit it for just a little bit. And so if you're younger than age 65 and you unfortunately get a terminal illness, there should be a hospice benefit under any commercial plan. Or what you're having to do is go and file for your disability, Social Security, and then you can, once you get that approved, then you can elect to be on hospice if your illness is progressing to the point where it looks like it's heading down. The other disease that I didn't talk about is dementia. End-stage dementia is also hospice appropriate. And those patients don't always die in 6 months. They stay on a lot longer. But it's a balancing act. It's a balancing act between those people that come on in 5 days and those people that will live a year. And it's also an honor to be discharged from hospice. You know, sometimes medicine doesn't get it right, and your illness will not take your life in the next 6 months, and you seem to be getting better. I've also noticed that on all the hospice patients that I've taken care of, they all get better when they get on the hospice. Why do they get better? Because all of a sudden their needs are being met. You've got people coming out to the home. You've got nurses. You have medicine. You have social workers. You have people that are engaged. Before, they didn't know where to go and what to do. And, of course, doctors sometimes don't always know about hospice or don't want to suggest it, because then it's like, I'm giving up on you. I'm not going to take care of you anymore. You're going to go home and you're going to die. And that's a horrible thing for doctors to say. Nobody wants to go down that avenue, but it depends on how your doctor presents it. And I've always presented it as a program to help patients when they have a terminal illness. And I ask the family, would you be surprised if your loved one died in the next 6 months? And when they say no, then I say, then you might want to think about hospice, because you need help in the home. And there is such a thing as caregiver burnout. Caregivers they get tired. I mean, when people can't get up to do anything and they're there 24/7, they do burn out. With that, I'm going to close the show. I want to thank, hope this helps you, Larissa. I was glad to do it for you. And I thank everybody for tuning in tonight. See you next Monday.